So, a very warm welcome and a very good afternoon to everyone, to all the listeners. A very happy new year on behalf of the ISA. And I am Dr. Nishant Sai. I'll be coordinating the session. Welcome to the online PG classes. And in this series today, we have a lecture by a very reputed professor, Dr. Girja Prasad Rath sir. It is my proud privilege to introduce him. He is currently the professor in the Department of Neuroanesthesia and Critical Care at AIIMS in New Delhi. He's also the executive editor of the Journal of Neuroanesthesia and Critical Care. He's in the board of directors of the Society of Neurosciences and Critical Care of the USA. He's a director at large there. And there he's serving as the editor in chief for their newsletter. Areas of interest, sir is interested in pediatric neuroanesthesia, neuromonitoring, awake neurosurgery, and brain death. He has received various honors like the ICMR International Fellow from the University of Washington in USA. He's the Fellow of the Indian College of Anesthesiologists, Fellow of the International Medical Sciences Academy, FIMSA. He has a lot of publications, more than 250 papers, more than 25 chapters, and he has edited 2 books. He is a very reputed speaker at various national conferences, the ISACon, the Indian Society of Neuroanesthesia and Critical Care Conference, the Research Society and Clinical Pharmacology Conference, the ISSPCon, and various international presentations and talks he has had. He was there at the World Congress of Anesthesiologists at Hong Kong, as well as this year in Prague. And he has given lectures in USA, Spain, and various Asian countries, Singapore, Japan, Malaysia, and Bangladesh. So it is an absolute privilege and honor to have Dr. Girja Prasad Rath to share his views, and he'll be discussing the anesthetic considerations for posterior fossa tumors, for posterior fossa surgery. So the plan for the day, sir, is we'll be keeping all the listeners mute till the time your presentation is going on. And once the presentation and the session is over, then we will open the session for question answers. All the listeners can, in the meantime, present their views and whatever doubts and queries they have in the chat box. Just in case there are any questions that you want to ask from the listeners, they can also answer that in the chat box itself. So we can take up everything once the session gets over. And over to you, sir.
Thank you, Dr. Nishant. Thank you for the kind introduction. So in between, I will be just discussing few aspects. In this presentation, I have not shared my experiences, my studies, because it is a PG class. It will be just like seminar. That's what Dr. Nobin suggested me. So I will try my best to cover everything, means whatever the experience I have directly or indirectly. So just now I'm sharing my screen.
Right, sir. Yes, sir.
Yeah. So very good evening to all of you, and wish you all a very happy new year. So I will be talking today about the anesthetic considerations for posterior fossa surgeries. I don't have any disclosure for this presentation. And in this talk, I will be covering all these aspects, the anatomical aspects, pathology, and various surgeries carried out in posterior fossa surgery, preoperative evaluation, preparation. So these are all broad headings which I have mentioned. But in the due course of time, I will be covering one by one: anesthetic technique, positioning, monitoring, different intraoperative complications and complications related to positioning, recovery, and postoperative care. So all these things I will be covering here. So we all know about the cranial fossa. Broadly, it is subdivided into 3 cranial fossae: anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. So today's talk will concentrate on posterior cranial fossa. And the boundaries of postcranial fossa, anteriorly it is clivus and petrous part of temporal bone. Posteriorly it is in the occiput. Laterally it is squamous and mustard part of the temporal bone. Superiorly it is tentorium cerebelli. It is not visible in this picture obviously. And inferiorly it is in the foramen magnum. So why this fossa is very important? It is because it is the largest of all the three cranial fossae, and it encloses almost 1/8 of the intracranial space. And more complexity is there are various intracranial anatomies with pathways regulating the consciousness, vital autonomic functions, motor activities, sensory receptions of the head, body, and extremities, centers for controlling balance and gait, and different complex vascular anatomies. And moreover, like the other part of this call, it is also compact, rigid, and there is poor compliance. Now, what are the contents of posterior fossa? These are all vasculatures, venous sinuses, bigger sinuses also present here. There are various neural structures, CSF. So all these are contents. We will discuss one by one. Now, what are the vascular anatomy? Blood supply is from vertebrovascular system, which is a paired system. So the clinical importance of vertebrovascular system is whenever we are doing positioning, if there is extreme neck flexion, there is a possibility that this vertebral artery may be kinked. Although it is not that common, we take appropriate precaution, but sometimes it is possible that we will have to keep in mind. Venous drainage, usually it is by the dural venous sinuses draining into the finally internal jugular vein. And as I mentioned in the previous slide, there are large venous sinuses like transverse sinus, sigmoid sinus, as you can see in this picture. My cursor is not moving. So these sinuses, there are clinical implications because of presence of these sinuses. Because whenever the posterior fossa surgery is carried out, there is possibility of inadvertent injury to these sinuses that may cause profuse bleeding, and there is also possibility of entrainment of air, which may cause venous air embolism. Now, what are the neural structures present in the posterior fossa? There may be cerebellum, brainstem, which includes midbrain, pons, and medulla, and different cranial nerves, starting from 3rd nerve to the 12th cranial nerve. And whenever the brainstem is involved because of certain lesion, there are ocular problems, cardiorespiratory problems, and multiple cranial nerve involvement will present with different signs and symptoms. The cranial nerve involvement usually occurs ipsilateral to a lesion, maybe it is a tumor, and motor and sensory changes usually occur contralateral to the lesion. This is what we must remember whenever we are proceeding with this anesthetic management. CSF, I am not going to discuss in detail about the CSF pathway. I presume that in the last class probably it has been discussed. And what I want to mention here is all these small foramens like foramen oculosca, Magendie, and the 4th ventricle. They are all there in the posterior fossa. So whenever there is a lesion, like a tumor or a space occupying lesion, that will cause obstructive hydrocephalus. So these patients will present in an emergency scenario. Now, what are the common pathologies involved in the posterior fossa? So there may be congenital anomalies like Arnold-Chiari malformation that may also present with hydrocephalus, vascular problems like AVMs, aneurysms. You must have heard about the basilar artery aneurysm. There may be other problems like cerebellar infarct because of any cause, or hematoma because of maybe it is traumatic, maybe it is any other cause. But most commonly it is tumors. The tumors may be intraaxial like ependymoma, medulloblastoma, astrocytoma, hemangioblastoma, or extraaxial like meningioma and schwannoma. Mostly the metastatic tumors are present in adults, whereas the primary tumors are quite common in the children. As you can see here in this schematic diagram, in children, also in adults, whenever a posterior fossa tumor present, it may present in the CP angle, or it may be involving the cerebellum, brainstem, and even the fourth ventricle. Now, the clinical features of these problems include the classic triad of headache, vomiting, and ataxia. There may be features of raised ICP, cerebellar compression, brainstem compression, and other dysfunctions of cranial nerve dysfunction, like hearing loss, like whenever the eighth nerve is involved, there is hearing loss. Similarly, there will be visual field defects, unsteadiness of gait when the patient is walking, facial muscle weakness, dilated pupil, taste disturbances, cough and gag reflexes may be affected, which is very important when the 9th and 10th cranial nerves are involved. So there will be absence of cough and gag reflexes, which will have implications in the postoperative recovery. Seizures are rare in posterior fossa surgery cases, or whenever a lesion is there. Usually these patients, they may not present with seizure unless the patient develops some electrolyte imbalances or hydrocephalus. The seizure incidence is quite rare. In children, the children may present with listlessness, same headache and vomiting, malnutrition, etc. Now, how to diagnose these problems? CT scan can be done on an emergency basis, particularly when the patient presents with hydrocephalus or a ventriculoperitoneal short or any other shunt, or maybe the patient present with some other symptoms. So MRI remains gold standard because it avoids the bony artifacts and it differentiates the intraaxial and extraaxial lesions, and it also visualizes the surrounding anatomical structures. As you can see here, you can clearly identify this is an MRI of brain. So you can clearly identify this is a fourth ventricular tumor, and these are all adjacent structures. I need not describe it. It is clearly demarcated anatomically, and this is a coronal section where you can see a CP angle tumor that is there. So what are the treatment for these lesions? The treatment is obviously surgical excision. If it is a vascular lesion, then also AVM needs excision, whereas aneurysms, they need either clipping or coiling. Whenever there is a clipping, so a proper follow-up, the anesthetic management, almost it will be similar like the one I am discussing right now. Now, what are the approaches for all these surgeries? There may be midline suboccipital craniotomy, which can be carried out in prone position or in sitting position, or paramedian suboccipital craniotomy, or retromustard suboccipital craniotomy, particularly in CP angle cases, which is carried out in lateral position. So before I proceed, I must ask here a question. I don't know where I can see it. The question is, cough and gag reflex are mediated through which cranial nerve? These are the options: 7th and 8th, 11th and 12th, 9th and 10th, 9th and 12th. Anybody? In the chat box, you can just write down.
Yes, sir. They are mentioning that in the chat box, sir.
Okay.
Mostly the answer is C.
I'm not able to see the chat box. How to go ahead with that?
So just below at the level.
Okay. So I came down. I'm finding problems here. Okay. Then I will have to minimize it. Okay, I got the chat box.
Yes, sir.
Yeah, good. Because most of them, they have mentioned 9th and 10th, which is correct. So everybody is listening, that means. Thank you very much. Now I will proceed with the next slide. Okay. So in the pre-anesthetic evaluation, one must look for the history and clinical examination. Other than the all other things we do, we should keep a documentation of previous surgeries. Like if the patient had underwent a shunt surgery, there is increased risk of pneumocephalus in the postoperative period. Whatever the pre-medications, preoperative medications the patients are taking, like to reduce edema, steroids, diuretics, and also antiemetics, that has to be continued. Cardiac and respiratory status, including the PFO, patent foramen ovale. Whenever there is a history of PFO, these patients, there is a contraindication for sitting position, so that must be recorded. Evaluation and documentation of lower cranial nerve dysfunction. As I mentioned earlier, and I asked that question, that cough and capital place, this is very important. One has to document it. And there may be evidences of cerebrovascular compromise. The patients, they might be having hypotension. So in those patients, if the head is elevated, in most of the neurosurgical patients, usually the head is elevated. So that may cause problems. So that has to be managed beforehand, before all this maneuvering is done. Then suitability of placing a RA catheter, right arterial catheter, like patients, some patient might be having obesity, there may be short neck, and also one has to look for the limitations and discomforts of neck movement in some of the patients. And these patients, the radiological diagnosis will have to be confirmed, and evaluation and optimization of other comorbidities which might be associated in these patients, and that will have to be done, and these patients need to be optimized before being taken up for surgery. And the routine blood investigations, that should include hemogram, coagulation profile, and renal function test, including the blood sugar, and that should also include various cardiac evaluation depending on the scenario the patient presents with. Now, what are the anesthetic goals? The anesthetic goals include, one is to ensure the adequate cerebral perfusion pressure, brain relaxation, and make all the maneuvers to facilitate proper surgical access for the neurosurgeon, facilitate neurophysiologic monitoring, like the patients may need intraoperative brain stem auditory potential, SSCP, MEP, etc., and provide immobility of the patient, minimize nervous tissue trauma, maintain respiratory and cardiovascular stability, and facilitate an early neurologic assessment at the end of the surgery. So these are all anesthetic goals that has to kept in mind. Now, what premedication should we give? Whatever the premedication, whatever the medication the patient is taking, that has to be continued, like the steroids, antiemetics, etc. But one must avoid sedative premedicants, because there is chances of respiratory depression, which may cause hypercapnia, increase cerebral blood flow, increase cerebral blood volume, and further increase in ICP. So that should be avoided. Even if you are giving some mild anxiolysis that might be having some sedative effects, so it should be given under supervision. But in my routine practice, I usually use anticialogogues whenever we plan for prone position and sitting position, particularly looking at the daily climate. Now, induction and intubation, it can be done with the either means intravenous or inhalational, particularly in children without an IV access. Inhalational induction with sevoflurane can be done. But whatever the induction method is, one must avoid hyperventilation, particularly in patients with large posterior fossa masses. Reason being, if you will hyperventilate, there is shrinking of brain in the supratemporal compartment that may cause reverse herniation. So although it is of theoretical value, because we are taking precaution, probably we are not encountering it. So one must avoid it in patients, those who are having large posterior fossa tumors. Propofol, it is most commonly used IV anesthetic agent right now. It has significant reduction for cerebral blood flow and metabolism, and it helps reducing ICP as well. And the endotracheal intubation can be felicitated with injection of fentanyl or any opioid and rocuronium. So otherwise, in our operating rooms, we are using rocuronium, but any other anesthetic means relaxants, muscle relaxants, that can be utilized. One must avoid hemodynamic responses to laryngoscopy like any other surgical procedures by additional doses of fentanyl, propofol, lignocaine, and short-acting beta blockers. And in my routine practice, I usually use flexometallic tubes. Earlier, when I think 10-15 years back, we used to use PVC. Still, in most of the centers, they are using PVC, but it is better to use a flexometallic tube in such a scenario because there will be extreme neck flexion in different positions. So, better to use reinforced endotracheal tubes. And after whatever the endotracheal tube you are putting, check for air entry with neck flexion prior to the fixation and final surgical positioning. Because once the positioning is done, it is very difficult to access the airway because everything will be covered after that. Now, what monitoring modalities are used? There may be certain routine monitoring modalities as we are using it in all other cases, along with certain invasive monitoring like for beat-to-beat heart rate and blood pressure monitoring, IBP, and CBP is also used depending on certain cases. The special monitoring includes multi-orifice RA catheters, particularly for sitting position to aspirate air entrapment. And precordial Doppler, whenever it is available, it is not available in our center, but a few centers in India is having precordial Doppler. We have transesophageal echocardiography, although it is not working at present. But whenever you have a transesophageal echocardiography, you should use it in sitting position cases to monitor venous air embolism. And some people also use transcranial Doppler for assessment of paradoxical air embolism, intraoperative neurophysiologic monitoring whenever it is required. But the most common monitoring utilized is special monitoring utilized is 7th nerve monitoring for CPNL tumors. Now, maintenance of anesthesia, usually balanced anesthesia with opioid and muscle relaxants is used. TIVA facilitates neuromonitoring and there is better surgical access. So nowadays it is commonly used and it has almost replaced balanced anesthesia, although we are divided in our department as far as whether to go ahead with balanced anesthesia and TIVA is concerned. That controversy still continues, but there are certain scenarios where TIVA can be utilized. In the last part of this talk, we can discuss all those things. But one has to consider maintaining CPP, and there is always a possibility of hypotension causing compromised CPP. So in those conditions, don't reduce the depth of anesthesia, rather control it with inotropes if the fluid transfusion is adequate, because decreasing depth will cause more awareness rather than solving the problem. One has to prevent and manage BAE and preserve the cardiovascular responsiveness to surgical manipulation of brainstem. At the same time, one has to look for if the surgeon is on the brainstem and there is brainstem handling, there might be certain hemodynamic changes, and don't go straight for atropine or any other beta blockers to control it. Rather ask the surgeon to relieve the manipulation, to avoid the manipulation for some time, and that will resolve the problem rather than giving all these medications because they will mask the very important signs of brainstem manipulation. Now, what is the use of muscle relaxants? There are certain advantages like it facilitate the ventilation and control EtCO2, and there is less severe CVS depression. It also prevent onward movement of the patient. It optimizes brain relaxation and visibility. But the problem with atracurium, it causes histamine release. So there is vasodilatation, hypotension, and further increase in ICP. And pancuronium, although it is not being used nowadays, that will also cause vagolytic effects and increase cerebral blood flow and increase mean arterial pressure. And muscle relaxants also makes facial nerve monitoring a difficult one. So one has to avoid whenever you are planning for facial nerve monitoring. Now, some people, they prefer using spontaneous ventilation, although it is of historical benefit right now because nobody uses nowadays. The advantages as per some of the anesthesiologists, it monitors the brainstem function relying on the changes in respiratory pattern. And some people say that with spontaneous ventilation, there is higher systolic blood pressure. So that way, there is less use of vasopressors. But the problem is it causes CO2 retention, and hence there is possibility of brain bulging in the intraoperative period. It also causes hypoxia and atelectasis, which might occur in long cases. And there is also a possibility of coughing and straining on the tube. And moreover, the negative pressure ventilation will facilitate further air entrapment, and that will cause increase in incidence of VAE. Although VAE during spontaneous ventilation, it may present with a gasp. Now, what about the fluid and glucose management? It can be managed with isotonic normal saline or balanced salt solutions. One must, like any other neurosurgical procedures, one should avoid dextrose containing solutions because there is chances of hyperglycemia, cerebral edema. So although these cases, there might be also a chance of hyperglycemia because of perioperative steroid administration. One has to keep an eye on the blood sugar values, and it has to be monitored in between, kept in between 140 to 180. If it is more than 200, then give insulin infusion. Then monitor hypoglycemia, particularly in children, in small children particularly, and one must target the urine output to a normal value. Temperature management, the goal is to maintain normothermia. There were certain studies which suggested mild hypothermia may be of certain value because it decreases the metabolism and may be having neuroprotective effects. But further evidences suggested that it is not that useful, and hence it is not recommended. And moreover, hypothermia may be complicated with coagulopathy, dyselectrolytemia, metabolic acidosis, etc. CPP catheter, preferably it should be placed in the neck veins. Usually we practice putting it in infraclavicular subclavian vein whenever it is required, and multi-orifice catheters are prepared, and the position of the catheter tip is 2 millimeters beyond the junction of SBC and RA. And one must take some precaution to avoid prolonged head down position in posterior fossa surgery cases and neck rotation while positioning for CPP catheter placement, particularly in neck veins. And ultrasound may be used. Nowadays, it is standard of care, not only for putting the central line, but also to know the catheter tip position by using T, which is again ultrasound. Now, there is also a way to insert CVP, and the catheter tip position can be done with biphasic P-wave identification by ECG guided means in lead 2 and B5. Now, what about the patient positioning? Before patient positioning, one has to consider about the age of the patients. Extremes of age is very important. So in those extremes, there is possibility of hemodynamic changes. And one has to look for the general fitness of the patient, particularly cardiovascular and pulmonary stability. And one has to see for surgical approach, what is the surgical approach so that the positioning should be so. And moreover, the airway manageability as far as the anesthesiologist is concerned. And what are the positions utilized for posterior fossa craniectomies? It may be supine with head rotation, which is less commonly used nowadays. In fact, it is less valuable. I will discuss it later on. Prone position, lateral decubitus, park bench, and sitting position. So all sorts of positioning can be utilized for posterior fossa craniectomies. Supine with head rotation. So here the head is completely turned to one side. It is rarely used for posterior fossa approaches, as I have mentioned earlier, but it can be utilized for CP angle tumors. Sometimes few of our neurosurgeons, they also practice that. And there is possibility of stretching of jugular vein and brachial plexus in this positioning. That is why the contralateral shoulder should be elevated to avoid this brachial plexus stretching injury. Now, prone position. Prone position, as you can see in this picture, this is the typical prone position. This is diagrammatic view, and this is how we make with the patient. Now, this is for midline posterior fossa lesions, and also some people, they do it for CV junction anomalies like Arnold-Chiari malformation, for example. In those cases also prone position can be utilized, and also in upper spinal cord lesions. And it is commonly utilized for pediatric patients, because in pediatric patients, most of the neurosurgeons, they don't prepare sitting position. So they straight away go ahead with prone position. And there is less incidence of DI in prone position, obviously, as compared to sitting position. But the disadvantage is there is excessive bleeding, injury to the peripheral nerves, eyes, difficult to resuscitate whenever there is cardiac arrest, and there is possibility of kinking and obstruction of endotracheal tube. There is extreme neck flexion, as you can see here, there is extreme neck flexion. So before we go ahead with prone position, one has to pre-oxygenate the patient with 100% oxygen, because there will be disconnection of all the things. So the timing of disconnection should be minimum, and maximum possible people should be present when we are positioning such patient. And the patient should be adequately padded with the level of chest, pelvis, elbow, and knees. Shoulders are placed at and above the edge of the operating table, and the head is elevated to avoid congestion, venous congestion, and it has to be supported by a horseshoe headrest. Nowadays, horseshoe headrest is less commonly utilized. So 3-pin skull fixation is usually utilized nowadays. Now, retract position. So here it is particularly useful for CP angle tumors, and it is the most commonly utilized position for CP angle tumors in our setup. As you can see here, it is a little bit modification of lateral position. You can call it as a park bench position. So this position, the advantages is there is drainage of CSF and blood from the surgical field by gravity. And so there is the surgeon, they get a better surgical view, because cerebellum is also away from the surgical field. But one must avoid peripheral nerve injuries by adequate padding of the pressure points. And there is also possibility of BQ mismatch in the dependent lung. Now, this is how the lateral positioning is done. This is the schematic view. As you can see here, there is a chest roll which is supporting the chest. And here, both the limbs, they are separated by a pillow. And this is the typical lateral position. This is the Concord position where there is reverse Trendelenburg, and it is same thing, it is repeated here. Now, sitting position. Here you can see a child is being positioned in a sitting position. And the main indications for sitting position nowadays is deep-rooted midline structures, lesions like posterior, third and fourth ventricular tumors, pineal tumors, for which we need supracerebellar infratentorial approach, brainstem lesions. And there are other indications like any other posterior fossa surgeries. Even CP angle tumors can be operated in sitting position. And some people even operate upper cervical spine in sitting position. So this is how a patient is positioned in sitting position. The reason being, we will have to do it gradually because there are possibility of hemodynamic instability during the positioning. So in our routine practice, usually we preload the patient with 5 to 10 ml of fluid. Then gradually, in a graded manner, the upper end and lower end are raised. And this is the next picture and the subsequent picture. And finally, you can see the knee is at the level of heart, and it is supported with a pillow. And similarly, at the buttock level, you can see also a soft pad that helps preventing injury to the sciatic nerve. And the 3-pin head holder is attached to the upper bar. Upper part of the table, and it has certain implications which we'll discuss later on. So all the bony prominences are well padded, and the elbow is also supported to avoid contact with the table and stretching on the brachial plexus. As you can see here, this is another child, this is another child. Then the legs should be free of pressure at common peroneal knob near the head of fibula. And one must restrict neck flexion to 2.5 centimeter or 2 finger breadth to prevent cervical cord stretching and prevent increase in airway pressures. Now, there are a lot of physiological changes that may occur because of sitting position. There is chances of increase in pulmonary vascular resistance, systemic vascular resistance, decreased venous return, cardiac output, even the CPP can be compromised because the systolic blood pressure usually reduced by 1 millimeter of mercury per every 1.25 centimeter increase in head level above the heart. And there are possibilities of dysrhythmias and various hemodynamic disturbances. Respiratory system wise, there is improvement in the vital capacity and FRC. The BQ mismatch is also reduced in upper part of the lung, but nitrous oxide, if you are using, that will increase the likelihood of transpulmonary passage of air. So there is possibility of a paradoxical air embolism, even if PFO may not be there. And there is a reduction in dural venous sinus pressure that will reduce the risk of bleeding, but then that will also increase the risk of venous air embolism. So before I proceed, I will ask the next question. Which position is least commonly used for post-op surgery? Supine, sitting, lateral, or prone? Which position is least commonly used for post-op surgery? Supine, sitting, lateral, and prone. Okay. So most of you till now have answered as supine, which is again correct. Thank you very much for listening to me. So the next thing is, what are the advantages of this sitting position? There are certain advantages for the neurosurgeon, there are certain advantages for the anesthesiologist, and also for the patient. For neurosurgeon, there is a better surgical exposure because there is significant reduction in the swelling of the lesion. And the surgeon gets a clear operating field because there is gravitational drainage of blood, CSF, and all the irrigation fluids the assistant forcing. There is also reduced blood loss and need for cauterization. And also it helps people say that there is better neurosurgical teaching, shorter operating time, and technically it is easier because the anatomical orientation is perfect here. For anesthesiologists, there is improved access to airway. So you can manage the airway to some extent, and also to the chest wall and the limbs. There is improved ventilation with lower airway pressures. There is unobstructed view of the patient's face and observation of motor responses, particularly whenever the cranial nerve monitoring is carried out. All the stimulations we can visualize through the draping because it is easily accessible. And it also helps in reducing ICP. So we need not do all the maneuvering to decrease the ICP. Now for the patients, otherwise these patients are operated in prone position most of the time, particularly in children, because post-op surgery is common in children. So there is reduced risk of visual loss. We can avoid prone position means there is reduced risk of visual loss to some extent. And there is also reduced risk of blood loss. Blood loss as such is decreased in sitting position cases. So the transfusion is also less. There is improved post-operative cranial nerve function. It has been seen in various literature, including my study, that the cranial nerve function is preserved in cases of sitting position as compared to the horizontal positions. But there are several contraindications for this sitting position. I have mentioned about PFO, but any intracardiac defect with right to left shunt, severe hypovolemia, patient if cachexic, and if there is severe hydrocephalus, open ventricular arterial shunt, which is an absolute contraindication, extreme age, impaired cardiac function, degenerative cervical spine disease, and significant cerebrovascular disease and signs of cerebral ischemia when the patient is upright and awake, which is otherwise known as orthodeoxia. That means the patient in supine stage, the saturation is well maintained, but when the patient is made sitting, then there is chances of hypoxia and ischemia. So what is the role of nitrous oxide in sitting position? It's a long controversy. The controversy still continues because in our center as well, we are still using nitrous oxide, although some people, they have stopped using it because it has analgesic values. So that is why we are using it. More than that, it reduces requirement of the second inhalational agent. And whenever there is VIE, it can be discontinued without any problem. That's what we have witnessed. But the problem is it increases the transpulmonary passage of air, as I have mentioned. There is possibility of paradoxical air embolism even in absence of right to left shunt. It also increases the size of the intravascular air bubbles if VIE occurs. It raises pressure in a closed airspace and leads to pneumocephalus and may even lead to tension pneumocephalus. And there are various complications that may occur. This table shows in different positioning. I'm not going to discuss in detail about it. Now, a little bit about osmotherapy in posterior surgery. The role is not well defined, but mannitol can be given in the actual dose to attenuate acute increase in ICP in some of the cases. But one must remember that in sitting position cases, there is chances of exaggerated hypovolemia leading to cardiovascular instability by mannitol transfusion. Also, there is possibility of electrolyte imbalances like mannitol itself. It causes some of the electrolyte imbalances. And there is also possibility of increase in the size of the pneumocephalus. Now, blood loss transfusion. One must do the careful dissection, particularly the neurosurgeon, and application of hemostatic agents like hemostatic sealants, and bone wax should be given, used liberally. That will reduce the bleeding. It is very difficult to quantify bleeding from neurosurgical cases. Same here in posterior fossa surgeries. And one has to ensure the blood is available all the time. And we can estimate the baseline hemoglobin and establish a transfuser trigger. Usually we follow a trigger of around 7 to 8 and maintain adequate precaution in pediatric patients and in vascular lesions in the posterior fossa, even if it is an adult patient. Now, what are the intraoperative complications? There may be tube kinking, accidental extubation, trigeminal cardiac reflex, hemodynamic disturbances in the form of hypotension and dysrhythmia, and venous air embolism. These are all most common intraoperative complications that may occur during posterior fossa surgery. Now, what is the cause of hemodynamic disturbances? Particularly whenever we are planning for sitting position, it has to be done in a graded manner, as I mentioned earlier. So that will cause hypotension and all other hemodynamic changes. And there are many such conditions. Manipulation of brainstem will also cause hemodynamic disturbances. Similarly, if there is severe BAE, if there is sudden blood loss, that will also cause hemodynamic disturbances. So one has to make adequate fluid loading, and whenever sitting position is being done, as I mentioned earlier, there should be gradual change of position. And one has to prevent and early treat the venous air embolism, warn the surgeon the presence of signs of brainstem manipulation. So there will be hemodynamic disturbances. There may be tachycardia, bradycardia, hypotension, and hypotension. If the surgeon is near the brainstem, just inform the surgeon. With that withdrawal of the manipulation, the things will improve. There is no need to give atropine or beta blockers, as I mentioned earlier. Use of compressive stockings in sitting position cases that will prevent venous pooling and will help maintaining the blood pressure. And whenever it is required, one can give vasopressors as well to maintain the hemodynamics. Now coming to venous air embolism, the incidence varies from horizontal to sitting position, and depending on the monitor used also the incidence varies. And it is because of open and valvulus non-collapsible veins like diplopic veins in the skull, and there is a negative pressure gradient, and that causes entrainment of air. And it can also occur during the excision of large vascular tumors and meningiomas, and also, as I mentioned, injury to the large venous sinuses may cause venous air embolism. So how VAE presents clinically? There is sudden sustained drop in EtCO2 more than 2 to 5 millimeters. If the entrainment is slow, the patient may present with hypoxemia, CO2 retention, increased pulmonary dead space, decreased EtCO2, increased airway pressure over a period of time due to pulmonary vasoconstriction. There is also decrease in cardiac output and blood pressure due to reduced venous return. But rapid entrainment will cause blockade of the right ventricular outflow tract. So there is acute ventricular dilatation, failure, and acute ventricular failure as well. There may be myocardial ischemia, dysrhythmia, and cardiovascular collapse. Although the doses of symptomatic dose and lethal dose that has been discussed in the literature, it is based on the animal experimentation. And I'm not sure about the values suggested in different textbooks. Now, what are the different VAE monitors available? There are sensitive monitors like transesophageal echocardiography and precordial Doppler. There are intermediate sensitive monitors like pulmonary capillary wedge pressure, EtCO2 and ETN2. But EtCO2 is most commonly available, so it is utilized, and whenever T is available, it is combined with EtCO2, and that gives the best of the values. And that is the best monitor available at present. And the low sensitive monitors may include CVP and pulmonary artery pressure. Then least sensitive are increase in heart rate, decrease in blood pressure, Millville murmur sometimes that may occur. So these are all least sensitive because these findings will occur in cases of severe VAE, which is the last stage. If you are monitoring vigilantly, then that should not happen. Now, EtCO2, the advantages are it is widely available, non-invasive, semi-quantitative, and it predicts resolution. As you can see here, this is EtCO2. There was sudden fall in EtCO2 because of VAE, and gradually the VAE resolved. Now there is increase in, the gradual increase in EtCO2. So EtCO2 predicts resolution in this way. But the problem is it is less sensitive and it is also non-specific. Whereas precordial Doppler, it is one of the most sensitive monitor and is non-invasive. But the problem is it is highly subjective. There is false negative in 10% of cases. It requires continuous monitoring. It is non-quantitative. It interferes with the electrocautery and also mannitol transfusion. And it is not useful in obese patients and patients with chest wall deformities. Whole chamber view helps in assessing the venous air embolism, which shows echogenic shadows. The advantage is it is highly sensitive. That is again a disadvantage for this T monitor. It also helps in preoperative screening of the patent foramen ovale, and it helps positioning the tip of the catheter in the right atrial catheter. But the problem is it is invasive, not quantitative. It cannot predict the resolution. So how to manage VAE? By preventing, and if it occurs, by treating. How to prevent it? With careful dissection by the neurosurgeon and hemostasis whenever required, and liberal use of bone wax, and preventing hypovolemia and improving the detection by different diagnostic modalities. But whenever it occurs, immediately inform the neurosurgeon, discontinue nitrous oxide if you are giving it, increase oxygen flow, modify the anesthetic but don't reduce the depth, and ask the surgeon to flood the surgical field with fluids, provide jugular vein compression if it is possible, aspirate the right arterial catheter, and provide cardiovascular support with inotropes. And finally, if nothing helps, then change the position of the patient. The patient position may be made supine. In my last 20 years experience, I have never encountered such a scenario which requires making the patient supine. You can manage the VAE without any problem. So there are various complications. I will just mention some of the postoperative complications of VAE. It may cause myocardial ischemia, right ventricular failure, perfusion defects in the pulmonary system, neurologic deficits, stroke and coma because of paradoxical air embolism. Now, postoperatively, one must take care to prevent hypoxemia whenever a VAE occurred in the intraoperative period and detect and treat MI if it is there. Paradoxical air embolism will have to be also monitored. That may present with stroke, and it can be diagnosed with air in the retinal vessels, although we don't practice it routinely with a fundoscopy. And if at all, if you can diagnose VAE, intraoperatively, if there is severe VAE, then one can go ahead with hyperbaric oxygen therapy if it is available. Otherwise, 100% oxygen will do. Now, before we further proceed, the question is, all the following are relative contraindications for sitting position except right to left shunt, patent foramen oval, ventricular arterial shunt, thicoperitoneal shunt. I'm asking about relative contraindications. So right to left shunt is a contraindication, obviously. Same with patent foramen oval. What about ventricular arterial shunt? So that may also cause entrainment of air straight away to the heart. So that is a problem. So that is again a relative contraindication. And some people, they don't at all use it. Even they consider it as an absolute contraindication. The answer should be thicoperitoneal shunt. Some of you have answered differently. We can discuss this later on. Any other suggestion for this question?
So we can encourage the listeners to type in the chat box if they feel any other way, as sir is mentioning, or we can discuss it, sir, after the class also.
Yeah. So I went through the chat box, and after that only I just responded because the answer is quite varied. So the answer should be thicoperitoneal shunt.
Right, sir.
Now we will proceed further. Nishan, the slide is not moving. Okay. So Now coming to emergence and extubation. The goals for emergence and extubation is to prevent abrupt increase in blood pressure and allow rapid awakening, minimize coughing and straining on the endotracheal tube. So what we should consider before we go ahead with emergence and extubation in posterior fossa surgery cases. The prerequisite is the patient should be awake, following commands and return of airway reflexes. So for that, one has to think about the preoperative neurological status, whether the patient was having deranged sensorium, cranial nerve function. We have already discussed the cough and gag reflex, whether it was intact or not, because there is possibility of aspiration if you extubate such patients with low sensorium, and the extent, severity, and duration of surgery. If it is a prolonged surgery, you will have to wait for some time. If there is massive intraoperative blood loss and transfusion, that also is an indication for postoperative mechanical ventilation continued for some period of time. And hemodynamic stability and the temperature of the patient, there should not be hypothermia.
Sir, your video is not coming. I'm sorry to disturb you. Video up off.
Okay. Now it is coming.
Thank you.
Now suppose the patient remains unresponsive at the end of the procedure after we give reversal. So one has to rule out the anesthetic causes and metabolic causes first. If that is not there, then we should think in the lines of pneumocephalus and hematoma, and there are other complications that may occur, like injury to the basilar artery if the surgery is carried out in that vicinity, brainstem compression, and there is a possibility of paradoxical air embolism. So all these things will have to be kept in mind, and an immediate CT scan should be done. Okay, so the question here is, the following statements are true about VAE. Which of the following statements are true about VAE? Surgery below the level of heart, decrease in ATCO2 but increase in ETN2, meal-feel murmur indicating minor embolism. Paradoxical air embolism can occur even without PFO. The answers may be multiple. I'm reading it again. The following statements are true about, which of the following statements are true about venous air embolism? It occurs when the surgery is carried out below the level of heart. There is decrease in ETCO2 but increase in ETN2. Meal-feel murmur indicates minor air embolism. Paradoxical air embolism can occur even without PFO. So the answers are yes. So it is also, so most people answered means at least one choice, one true choice. But let me to clarify those who have answered C. The first thing is, all right, everybody is clear about it. The second aspect is true. There is decrease in ETCO2, but increase in ETN2. Meal-feel murmur indicates minor, it's a severe embolism will cause meal-feel murmur. The paradoxical air embolism can occur even without PFO. I have mentioned in some of my slides that if you are using nitrous oxide, there is transpulmonary passage of air that may cause also paradoxical air embolism. So even without patent foramen valve, there is possibility of paradoxical air embolism. So the answer is both B and D. So let us now proceed. Next slide. It's not moving. Yes. So postoperative mechanical ventilation. Which of these patients they require postoperative mechanical ventilation? Usually patients, those who are having large and deep-seated lesions, and whenever there is maximum brainstem handling, because that may lead to edema in the postoperative period, and the patient may develop further problems, even though in the immediate postoperative period, the patient might not be having problem and is extubated uneventfully. The patient may develop further problems later on. And whenever there is significant intraoperative blood loss or massive fluid shift, and if there is more requirement of intraoperative vasopressors and inotropes, which continues for postoperative period, in those patients, postoperative mechanical ventilation is usually required. Now, how to take care of these patients in the postoperative period? The patient may be mechanically ventilated in the postoperative period or may be extubated. So depending on that, the patient should be monitored with the GCS along with hemodynamic monitoring. And whenever there is any issue, and one has to go for imaging modalities. Now, what are the postoperative complications following post-operative surgery? The list is quite big. It may range from pain to PONV, macroglossia with airway obstruction, tensor pneumocephalus, hydrocephalus, cranial nerve dysfunction, hematoma, dyselectrolytemia, infections, seizures, quadriplegia, peripheral neuropathies, and postoperative vision loss. So I will just enumerate few of them. So how to manage pain in the postoperative period? Actually, post-operative surgery as compared to other craniotomy cases, the incidence of pain is more. It is because traction of the scalp, including different musculature like occipitalis. So in these cases, multimodal analgesia can be used, which includes NSAIDs, short-acting opioids like fentanyl, which is also helpful as a sedative in intubated patients, and along with a scalp block, which can be given after induction or just some time before the possible extubation. Postoperative nausea, vomiting, again in postoperative surgeries as compared to other craniotomies, it is more, and it also depends on the longer duration of surgery and subsequent increased exposure to anesthetics and analgesics that will increase the risk further. So these patients might already be having dexamethasone. So we can give ondansetron or any other antiemetic agents to prevent and treat it. Tensor pneumocephalus, it occurs as a result of CSF leak through the incision site. So air enters into the subdural space and it can cause brain herniation because of mass effect, as you can see in this image. So this hypodense shadow is actually air. And here there is in ventricle also, in lateral ventricle also, you can see air. This portion is air, this dark portion is hyperdense portion. So it is compressing the frontal region, and there is picking up the frontal region bilaterally, which is known as Mount Fuji sign, which is pathognomonic of tensor pneumocephalus. And so it is a life-threatening situation. It is a real emergency. These patients usually they present with delayed reversal, altered sensorium, confusion, headache, convulsion, and neurological deficits. So in those conditions, one should go ahead with urgent CT, and if the diagnosis is confirmed, then go for 100% oxygen to still borehole evacuation of the air. Macroglossia, as you can see here, in this patient, there is macroglossia along with the lip is also swollen. So there is a nasopharyngeal airway given to maintain patency of the airway. So that may occur because of obstruction of venous and lymphatic drainage of the trunk. And sometimes there is extreme flexion of the neck and presence of an airway. And sometimes whenever we are using T, we'll have to be extra careful because extreme flexion in that scenario may cause macroglossia. So there may be also swelling of other pharyngeal structures. So in that condition, it is better not to extubate these patients and wait for some time before it subsides. Some patients, although it is very rare because you are taking extra precaution, they may present with quadriplegia, which is otherwise known as mid-cervical flexion myelopathy. So it occurs because of acute flexion of the cord at the level of C5, and usually it is because of compromised regional cord perfusion. It is common in degenerative diseases of upper cervical spines. Now, there are different peripheral neuropathies occur because of faulty positioning and prolonged surgery, like brachial plexus, ulnar nerve, common peroneal, sciatic nerve. These are quite common in posterior surgeries. There may be presence of recurrent nerve palsy in sitting position, and in these cases, T is implicated to be behind this recurrent nerve palsy. So, just to summarize my talk, posterior fossa surgeries are complex procedures with limited space and proximity to the vital structures. Preoperative documentation of the neurological deficits and lower cranial nerve function is of paramount importance. Appropriate patient positioning and adequate management of intraoperative complications are major challenges for the anesthesiologist, and the postoperative care should focus on pain management and recovery of respiratory functions, especially in patients with lower cranial nerve palsy. Thank you very much. So now we can go ahead with the discussion. Dr. Nishant, over to you.
Yes, sir. Thank you so much, sir. And thank you for the elaborate lecture, and right from the preoperative period, replete with all those diagrams and the actual photographs of the patients. I'm sure it must have been a very, very useful lecture for all the postgraduates, as well as some of the teachers who are listening to this lecture. So for the information, sir, every Monday the ISA holds these postgraduate ISA online classes, which are now from 5 to 6:30, and these can be seen on the ISA website as well as the YouTube channel. This is for the benefit of those people who are not able to see it now. They can just revise on all these lectures from the YouTube and the ISA website channels. So, sir, if you permit, we can take a few questions that have cropped up in the chat box.
So should I stop the screen sharing?
Yes, sir, you can stop the screen sharing.
Okay.
Dr. Harsha Desai wants to know about your opinion on the use of opioids versus non-opioids for analgesia for these posterior fossa surgeries.
Yeah, means opioid, no doubt, it is the best analgesic as far as the post operative cases are concerned. But then if the patient is intubated, obviously we can go ahead with giving opioids even in infusions if you want to continue with mechanical ventilation. But then obviously in extubated cases, it is better to avoid, even though you are using it in the ICU. Because at any point of time, if there is because posterior fossa is very small, if there is a slightest edema or a small hematoma, even if it is there, that will compress the brainstem, and suddenly the patient will be unresponsive, not because you gave opioids, but because the patient will collapse because of compression of the brainstem. All the vital centers are there. So that is why it is better to avoid it. And it is in our routine practice, we are giving NSAIDs like paracetamol, IV paracetamol commonly we are using. Nowadays, we are also giving some of the anesthesiologists, they are practicing the scalp block along with that. So
Yes.
that is how we are doing. And
Yes.
even if we are giving opioids in few of the cases, it is in a graded manner and under supervision only.
Right. So you mentioned in your talk also that it has to be a multimodal analgesia.
Yeah.
So the next question is by Dr. Veena. She wants to know about the response of end-tidal carbon dioxide on the venous air embolism.
So end-tidal carbon dioxide means it causes pulmonary vasoconstriction. That's what I mentioned. So there is chances of increased airway pressure because of that. So if you are monitoring the patient, you can actually look for increase in airway pressure. And if it is more, and if you are not able to resolve it immediately, over a period of time, there will be more and more VAE that will compromise it further. There may be some hemodynamic changes also. And finally, there will be hypotension, bradycardia. All these things are going to happen. But in initial stage, there will be pulmonary vasoconstriction.
Right, sir. So there's another question by Dr. Mitali Agarwal. She wants to know about zeroing of the invasive blood pressure in the sitting position. How do you zero in a sitting position?
So Usually we zero it at the level of tragus because all the basal vessels are there. So that is how we do it. That is, every standard book writes that, and I think I have not mentioned it. That is why she is asking about it. It is at the level of tragus.
It's the level of the tragus. Dr. Muthu Kumar wants to know about, he's mentioned Durance, actually Durant's position for VAE, D-U-R-A-N-T, Durant's position for venous air embolism.
So it is not used. This is of theoretical importance. As I mentioned to you, even changing of position is not required if you are vigilant enough to monitor VAE. So I have done so many cases of sitting craniotomy, but never I have encountered in such a condition where the hemodynamic changes are so much that I need to make the patient supine. So all these positions are described in terms of theoretical interest. It is no more practiced.
Right, sir.
But yes, if it occurs, that is the last resort. But if you are sure about your monitoring, there is no problem as such. It doesn't require all these things.
Okay. So Dr. Veena, there's a question by Dr. Veena regarding what precautions should we take so that there is we can prevent the rise of blood pressure during extubation in these surgeries.
Extubation, you see, means normally the practice is, I have seen most of the people, they stop all these anesthetic agents much before it is required, and they fear about this opioid hangover, which is not true. Ideally, what in my practice, what I do is 45 minutes to 1 hour before possible extubation, I give the last dose of opioid, or if there is a continuous infusion, I stop it at that point of time. That is number one. Second thing is the inhalational agents, before pin is removed, we don't switch off it. So there is less possibility of hypertensive response. But yes, there are certain conditions where there is increased incidences of hypertensive responses. So in those cases, like you can use certain beta blockers, like some people, like I will tell you, in Vellore, a study by Grace Karula and colleagues, they carried out, they used lignocaine, and in some of our cases also we used lignocaine, and it effectively manage the rise in blood pressure. And some people use also low doses of opioids. So that is also doable because you are doing it under controlled condition. You can do all these things, and these are all well documented things, and that is there in the literature.
Right, sir. So there's a question by Dr. Uzma. Is there a possible minimum age for the sitting position?
There is no age described, but if you can tell me, up to 3 years, I have done cases, 3 to 4 years, and the literature, I was going through the literature, they have used up to 3 to 4 years. There is no age cutoff, but yes, extremes of ages is relative contraindication. If younger is the child, there is more possibility of complications. But I will tell you, I have done 3-4 cases in that age group, like for 3 to 10 years. There was hardly any problem. Like any other case we do, we did that.
Right, sir. So Dr. Muthu Kumar wants to know what TIVA do you use for posterior for surgery? What infusions or something?
Propofol, usually propofol and fentanyl combination.
Propofol, fentanyl. And Dr. Veena again wants to know if we can use levotalol just prior to extubation to control the blood pressure, just as you were saying.
Yeah, because the surgery is over, you can go ahead with using labetalol if at all it is required. You see, what my experience with esmolol is, esmolol reduces the heart rate more than the blood pressure. And don't give the full dose. Sometimes these patients, Indian patients, are very responsive. Even if you give a very small dose, the patient will be having all sorts of effects. So check for the effect of this patient, that particular patient, and after that you give that particular dose. So that is how. Otherwise, labetalol is best, obviously.
All right, sir. So there's a question by Muthu Kumar about dexmedetomidine. Last week also, sir, we had a little discussion on the use of dexmedetomidine in neurosurgeries. Dr. Karnik ma'am is here. Whether dexmedetomidine can be used for TIVA?
Yes, that can be used nowadays. It is a fancy, means people have started using it, and why dexmedetomidine in spine cases people have started using ketamine. Ketofol is a standard method right now. So
Right.
all sorts of, even I came to know that there is a drug in combination of ketamine and dexmedetomidine is now available since last couple of months. So Ketodex, so that is being used. So all sorts of medication you can use. It is not important which medication you are using, how you are using, what is the scenario, that is very important.
Correct, sir. So what I have done is I have allowed everyone to unmute themselves just in case there is some question, query, or their experience. They can just share it with you directly.
Yeah.
We see we have Dr. Agnihotri sir and we have Dr. Karnik ma'am here. So if anybody wants to ask anything or share any views, Dr. Naveen sir.
But I have what compliments for Dr. Girija for making it so simple, and I thoroughly enjoyed over last almost 70-75 minutes or so. Let's have questions from others and then we can conclude later on.
Yeah, somebody asked about use of nitroglycerin in the intraoperative period. Nitroglycerin, you see, it causes cerebral vasodilatation. So in neurosurgical cases, I think I used last time in my residency, 20 years back. I never used nitroglycerin. It is not required now. So we don't use it.
Can I make a comment?
Yes, yes,
Yeah.
madam.
About the nitroglycerin, you also mentioned several ways of controlling the blood pressure during extubation.
Yes,
and we did use nitroglycerin spray during extubation, and the time duration that is required for that hypertensive response of extubation, roughly the spray also gives the protection for the roughly same time. So we used it for plenty of patients. By that time, the ICP is reduced, tumor is removed, and also it was very useful for extubation time for prevention of hypertension.
Agree, madam. And that is spray and at the time of extubation.
Yeah.
This question was for intraoperative use.
Yeah, this question was intraoperative. I just correlated those two answers. Yeah.
Thank you.
Thanks.
Any other question or comment? So I think we had a very good beginning for the new year 2022 in the Platinum Jubilee celebrations of Indian Society of Anesthesiologists, as we were formed in 1947 and now we're entering into 2022. And yes, academics will grow in leaps and bounds in this Platinum Jubilee also. And we will have more esteemed faculty with us in every Monday. And we'd like to have Dr. Girija Rath also after a few months again with us on some other topic. I once again thank Dr. Girija for sparing your valuable time and be here with us, sharing your experience as well as other details to our dear postgraduates, private practitioners, young faculty, senior members, and all alike. Thank you all for your patient listening and good interaction during the questions. And there was an active participation during the question answer sessions also. See you all next Monday, 5 p.m. Thank you very much. Wish you all a very happy new year. May you and your family remain happy and healthy. And please do take care, do take good care of yourself. Thank you very much.
Thank you very much.
Thank you, sir.